Thank you for joining me today. In this video, we are going to go over medication called Trazodone. Trazodone is an antipsychotic medication, and Trazodone is serotonin reuptake inhibitor. Trazodone is only prescription medication. There is no over-the-counter medication. Trazodone has a tablet. It has immediate release. It has extended release. Also, it has an oral solution. So it has couple forms. It comes to couple forms. Trazodone is approved for major depression disorder. It improves the mood. It improves anxiety, appetite, sleep that associated with depression. It has also off-label usage. And the off-label usage is very common but not FDA approved. It used the insomnia, so it's used for sleep. It's used for anxiety disorder. It used also PTSD. Those are the off-label use because it helps the insomnia and night terrors. It's also used the fibromyalgia pain, substance use disorder. Trazodone, some of the side effects are sedation, drowsiness, dizziness, orthostatic blood pressure. So it will lower your blood pressure, dry mouth, nausea, constipation. It leads to headache. It affects the cardiovascular also, and it prolongs QT prolongation. It causes QT prolongation, arrhythmia that can lead to heart failure. It leads to heart palpitation, syncope, which is dizziness. It has serious side effects and has black box warnings. Some of these black box warning and serious side effects include suicidal thoughts and behavior in children or teenagers less than 24. It's rare, but it's medical emergency called bariatric, which is dangerous. Bariatric, which is medical emergency and dangerous. It leads to serotonin syndrome, especially if you are taking SSRIs or SNRIs, or if you are taking MAOIs. It leads to serotonin syndrome. It leads to hyponatremia and sad deaths, especially older adults, seniors, especially seniors. So you have to be monitor this patient when you are taking this patient or when you are prescribing this medication. You have to monitor this medication. You have to monitor the mental status, assess the mental status. You want to assess mood changes. You want to assess suicidal ideation, especially early treatment or if the dosage changes. You want to monitor the blood pressure because it lowers the blood pressure and has a risk of orthostatic blood pressure risks. For cardiac, you have to monitor cardiac. You have to have a baseline EKG if the cardiac risk is higher or if the patient have any cardiac issues. You want to monitor QT prolongation, and if they are taking medication that increase also Q, you don't want to take them or prescribe other medication that also increase a QT prolongation. For elderly, they are risky of sodium imbalance. So you want to check the electrolytes. Affected side effects include excessive sedation. For men, it can lead to bryopepsia. You can search that word. Okay. Patient education. You will educate the patient to take this medication after meal with night snack. You will take the medication with food, so that can reduce the GI upset like a nausea and vomiting, and it will help with that. You will educate them sedation, that is common. You will educate the patient and advise them to take this medication at bedtime. Avoid driving until effects are known. Don't take this medication and drive. Do not stop this medication quickly. It has to be tapered gradually to prevent withdrawal of insomnia and anxiety, because if you quickly stop this medication, you will experience insomnia and anxiety. You will educate the patient to report immediately if they are having suicidal thoughts, painful or prolonged erection equal to or more than 4 hours, fainting or irregular heartbeat. You wanted them to report that. So Priapism symptoms is a prolongated erections that is 4 hours or more, and that is medical emergency. They should go to the emergency and report it quickly. Clinical boros is commonly used as a smaller dose. Trazodone is used a lower dose of 25 milligram to 10 milligram for sleep, much lower than antidepressant dosage. Antidepressant dosage, the dosage that you use for antidepressant, you start slower and you increase slower. You start slower, you monitor the side effects and treatment outcome, and then you increase slower. If you need to, if the lower dose is enough and the patient are doing good, you don't have to increase anything. Highly sedative. This patient is highly sedative due to histamine and alpha blocker. So this medication blocks histamine and alpha 1 blockage. Minimum anticholinergic effect. It has a minimum anticholinergic effect. Safe. It's safe than ACTA. There's a medication, anti-depression medication called ACTA. So this one is safer in elderly, but it still has a risk of high falls. It can lead to falls for elderly, but it's less than TCA medications. It is rare, but it has erection prolongation is a classic broad style of face effect. So it has that side effects. Not the first line anti-depression medication. So this is not the first line anti-depression medication, but useful for insomnia and is prominent. You will monitor QT prolongation risks when combined with other QT prolongation agents. These videos are education only. Please talk to your provider. I am not your doctor. I am not here to teach you. I am here to teach the students what to look for before they prescribe this medication. So if you have a question, please talk to your provider. I have a story-based case study based on Trazodone that I want to continue. So Trazodone, it was the fourth night of a hospitalization when the nurse paged me about Mr. J. So the nurse paged me about Mr. J. She is a 74 years old woman admitted for COPD exacerbation. So the Trazodone, this 74 years lady was taking the Trazodone. It was the first night of a hospitalization when a nurse paged me about Mrs. J, who admitted for COPD exacerbation. Her oxygen needs were improving. So her oxygen was improving. Steroid tapering lab is stable. But every night follow the same pattern. She is not sleeping, the nurses say. And tonight she is starting to get confused. So this 74 years is not sleeping. She is getting confused. When I went into the room, Mrs. J looked exhausted in a way that felt precocious, not agitated, not hallucinating, just wandering down. I closed my eyes, she told me, and my mind won't stop. Then someone wakes me up. Then the machine keeps beeping. Then I forget where I am. So this 74 years old has insomnia and she's in the hospital. She couldn't sleep. Nurses were waking her up. Machinists were waking her up. Her vitals were stable. No new hypoxia, no infection, no pain control. This was not delirium yet, but it was heading here. So this was not delirium, but she has that confusion. We did already done the night. We already done the right first thing. Lights were dim. Care was clustered. We give her air blankets. We give her melatonin at night. None of this helped. This was the moment where insomnia stops being and start to matter. I did not want benzodiazepine. I did not want Z drugs. I did not want to solve sleep by creeping respiratory compromise, falls or delirium. So I don't want her to have respiratory compromise. She already have a COPD, and that's why she's admitted to the hospital. We don't want her to fall or have a delirium. We don't want her to take benzodiazepine because those will cause her those things. And we don't want it Z-drugs. So Trazodone is not crack out punch. It does not silence the brain. It not sleep physiology back to where something recognizable, especially when the problem is a sleep initiation or fragmentation, not psych or agitation cause. So Trazodone you use when the sleep initiation is the difficulty or fragmental, not psych or irritation. If the patient has a psych issue or irritation, you choose different medication, not this one. So we started slow. About an hour later, I checked back in and the lights were still dim. The monitor was quiet. Mrs. J was asleep, not sedated, not abrupted, just sleeping. Her breath was slow and steady. Oxygen saturation was unchanged. By the morning, she was different. How different? Hopefully better. She said, I slept not all night, but enough. That's what she said in the morning. That was the turning point. The next night looked better. And the one after that. Her orientation returned. No night time confusion. No escalation to antipsychotic. No falls. We stopped the serotonin before discharge because it's short-term use, not continue using that medication. That case is stay with me because it reinforced a lesson that is to undervalue inpatient care. That case stay with me because it reinforced a lesson that is to undervalue the inpatient care. Sleep is not optional, and Trazodone can be preventable intervention. It asks, are we treating insomnia before it becomes delirium? That is the question. Are we treating the insomnia before it becomes delirium? Are we choosing the medication that respects the respiratory drive and cognition? Because this medication is not going to suppress your respiratory and make you confused more. Are we using the lowest dose for short term with clear stop plan? That means this medication is used short term in a lower dose and stopped. You have to have a clear plan to stop this medication. Trazodone is not dramatic, but when used thoughtful, it can quickly protect the brain. So the treatment plan for this treatment is it's indicated hospitalized associated insomnia. It helps sleep fragmentation, contributed to early cognitive changes, failure of non-pharmacological measures alone. That's how you use this medication when the non-pharmacology measures didn't work, when the patient having a fragmental sleep, and when it's the earlier cognitive changes, and it's hospital-associated insomnia. And medication strategies is you will start lower dose at bedtime. Trazodone, you will take lower dose at the bedtime. You avoid dose increase without reassessment. You avoid combining with other sedative medications. You will review daily with intent to discontinue prior discharge. And support measures include sleep wake cycle normalization, minimum night interruption. Daily movement, you encourage the patient to increase their daily mobility, walk, exercise. You will encourage them to sunlight exposure, because you want to adjust their sleep wake cycle. You want to orientate them as needed if they are confused. Patient education is, so I explained to her, poor sleep in a hospital is a common and can affect thinking and recovery. Trazodone helps promote sleep without acting like a traditional sleep pills. It is meant to be a temporary, not new chronic medication. We review standing up slowly in the morning. We report if you feel dizziness, excessive grogginess. Let the staff know if sleep worsens or confusion returns. Some of the side effects to monitor is morning grogginess, dizziness, headache, orthostatic blood pressure, long cubar elongation, risky falls, particularly overnight, balance issue with a rapid positioning changes. If you quickly change your position or stand up quickly or lay down quickly, you can feel dizzy or fall. Dry mouth. If it's man, long erection. The treatment outcome that you are looking for will be improved sleep quality and duration, no delirium developed, no respiratory compromise, no hypotension or lowering the blood pressure. Those are the outcomes you are looking for. No falls. Trazodone discontinue prior to discharge. Patient discharge orientated and cognitive fit at the baseline. Those are the good outcomes you are looking for. So my question to you is, when managing insomnia in a hospital patient, how do you decide when the medication like a Trazodone are appropriate? When do you decide? How do you balance sleep monitoring with fall risk, overdose, and delirium prevention? How do you balance sleep monitoring with the fall risk, over sedation, and delirium prevention? Those are my questions to you. Thank you for joining me today. I would love to see you in my next videos.